Hello and welcome to the Neurocritical Care Society podcast. I'm your host, Dr. Nick Morris from the University of Maryland Shock Trauma Hospital. And today, as part of our Hot Topics series, I'm really excited to get to discuss the recently published SWITCH trial with two of the lead authors, Dr. Jürgen Beck and Dr. Urs Fischer. Really excited to have you on the podcast, and I know a lot of people are excited about this trial and want to talk about it. So thanks so much for coming on. Maybe if you could just start by giving people a little bit of an introduction to yourselves, so we kind of know what your backgrounds are and how you're coming to this. So maybe we'll start with Dr. Fischer.
Yeah, thank you very much for having us. My name is Urs Fischer. I'm the chairman of the Department of Neurology at the University Hospital in Bern, Switzerland. I'm a clinician scientist, and I'm interested in the unanswered questions in acute stroke management.
Fantastic. And Dr. Beck?
Yeah, welcome from my side. My name is Jürgen Beck. I'm head of the Department of Neurosurgery in Freiburg in Germany. And my focus areas are the tumors, vascular neurosurgery, and CSF disorders. And currently I'm focusing on intracranial bleedings and the SWITCH trial.
Wonderful. So I think probably there's been no area that's been more exciting in neurocritical care over the last even just several weeks, but probably several months than intracerebral hemorrhage. And we're finally starting to see some real breakthroughs here. And I think the SWITCH trial really gives us a wonderful option for some of the most severely affected patients. But maybe we can take a step back and talk about some of the previous trials that have occurred in this space and what they've taught us, and maybe discuss, by your estimation, why have some of these older approaches not succeeded in improving outcomes for patients with severe or deep ICH? Dr. Beck?
I think we've learned a lot from the older trials, and without these older trials, ENRICH and SWITCH wouldn't have been possible. And they were excellent trials. It's tough to make a clinical trial in ICH, especially a surgical trial, and we've learned a lot from STITCH 1 and STITCH 2 and MISTY. First, it's feasible to conduct such large trials, and there was a slight improvement in outcome. But we've learned really a lot concerning the criteria, the inclusion-exclusion criteria. What are the best the patients we must select for a surgical trial? We learned a lot about timing, that we probably shouldn't wait the days until we begin to extract the hematoma, to evacuate the hematoma, and clearly, without STITCH and MISTY, the current trials that seems to be effective wouldn't have been possible at all. So thanks to the people who conducted these excellent trials.
Dr. Fischer, what did we know about decompressive craniectomy for deep ICH before SWITCH?
A good question. There were only retrospective case series on that topic, and they suggested that there could eventually be a treatment benefit, but there was no single randomized controlled trial on the topic. We had some experience, obviously, in people with malignant ischemic stroke, and there we know that decompressive surgery is highly effective. However, whether that works for people with severe deep ICH was completely unknown.
Great. And, I think sometimes we forget about the older trials and sort of exactly what they did. And in SWITCH, right, very few patients actually had decompressive craniectomy, mostly had craniotomy. Maybe we can kind of jump right into the trial now. And Dr. Beck, maybe you can take us through, you mentioned how important the inclusion-exclusion criteria are for any trial. What were the major inclusion and exclusion criteria for SWITCH? And I'm particularly interested in the inclusion of patients with phalamic ICH because, as you know, those were not included in the ENRICH trial. And I'm wondering how you decided to include those in SWITCH.
Excellent question. The main line is for the inclusion criteria for SWITCH is that we included severely affected patients with only deep hemorrhage of the brain and large deep hemorrhage. So the mean size of our patients, of the volume of in our patients was around nearly 60 cc's, only in the depth of the brain. And to be honest, this is the most severely affected patient group. And this also implies, of course, to what population can we extrapolate the SWITCH results. And this, we are very clear on that. Only to very severely affected patients with deep ICH, we should even consider craniectomy. And the second question, why thalamus? to be honest, we designed the trial 14 years ago, and we weren't really probably as clever as the enriched guys were to exclude the thalamus. And so we have the severest group of patients, including the thalamus. And we know from the INTERACT trials that thalamic bleedings do have a worse outcome. So this leaves really the people who could apply for switch or could be elected for switch are the most severely affected patients, probably only 2 to 5% of all patients with ICH.
Great. I think it is a small portion of patients with ICH, but probably at some of the major academic centers, our patient populations are enriched with these, no pun intended, with these severe deep ICH patients because other centers don't want to take care of them. And so I think for someone that practices somewhere like I do, this trial really speaks to me because I see, unfortunately, too many patients with deep, severe ICH.
Yes, Nicholas, and probably another important point is why we had chosen these selection criteria is there is no other treatment available. There is simply nothing. So this is why it makes so valuable to consider DC in these patients. There is no other treatment.
Great. Well, let's maybe get into the protocol a little bit. You mentioned that the timing is important. So what was the timing of the surgery?
Yeah, I can briefly comment on that point. So basically, patients had to be randomized within the first 66 hours, and then surgery had to be done no later than 6 hours after randomization. So basically, within the first 72 hours, patients could be included in the trial. Nevertheless, we know from the data of the trial that the vast majority of the people were randomized after 24 hours, so after 1 day. And I think that's an important point. When we designed the trial, we were scared that with the decompressive surgery, we could, eventually trigger active rebleeding of the hematoma, and we couldn't observe such a treatment effect in the switch trial.
Got it. And Dr. Fischer, were there any exclusion criteria for patients who were perhaps unlikely to benefit because it was too severe, maybe GCS too low or rapidly declining or fixed dilated pupils?
Yes. So we had quite narrow inclusion-exclusion criteria because we wanted to select on what we thought the correct proportion of people who would benefit from such a severe intervention. So we were focusing on people with a Glasgow score of more than 7 and less than 14. They needed to have an NIH score of 10 and more and less than 30. And the ICH volume, and I think that's important, was 30 mil, more than 30 mil, and less than 100. Furthermore, we had people with a structural lesion in the brain, for instance, an AVM or something else. They were excluded. We also excluded people with severe dementia, bilateral reactive pupils, and also people with prior symptomatic ICH. So we really wanted to focus on this middle group where we thought the treatment benefit of a decompressive surgery is given.
Great. And Dr. Beck, you mentioned that we really don't have any other treatments for these trials. So the comparator here was best medical therapy. And obviously the patients who received decompressive craniectomy also got best medical therapy. But just to be explicit, what did that entail for these patients?
Rapid reversal of anticoagulation, best medical treatment on the neuro ICU or stroke-like conditions. So a strict adherence to avoiding hypertension, avoiding fever, normoglycemia, and all this. But we know what's beneficial in stroke trials and stroke units in neurointensive care.
Great. Let's maybe shift a little bit to the outcomes here. So I thought the outcome that you chose was interesting, and I think probably something a lot of people are talking about when they talk about this study. So Dr. Fischer, what was the primary outcome, and how did you go about choosing it?
Yeah, excellent question. We had a long debate how we should define the primary outcome. And please keep in mind, we designed the trial more than 10 years ago. So at the time, first of all, shift analyses were not very common. That's something which we have to consider. Second, we had to define a realistic primary outcome. Already at the time when we defined our inclusion-exclusion criteria, for us, it was clear that a modified ranking scale of 0 to 3 versus 4 to 6 would be overambitious. because it's not realistic, then in this severely affected cohort, you're going to improve the modified ranking scale of 0 to 3 versus 4 to 6. So that was the reason, based on historical data of Joe Broderick, we defined the primary outcome of 0 to 4 versus 5 to 6. We aimed not to shift people from a 6 to a 5. Our aim was to shift people from a 6 to a 4. So I think that's a realistic outcome for such a severely affected cohort.
Yeah, I agree. I was lucky enough to be part of the Step Point 2 trial, which was led by Dave Cedar and Julian Vossel. And that trial, if you remember, was funded by a patient-centered organization, PCORI. And I know in that study, when they were planning the investigation, they had to include either patients that survived with ICH or their surrogates. And initially, they actually dichotomized at 0 to 3. And the patients and their surrogates were outraged that a 4 was not a good outcome for patients with severe stroke. And so they expanded to 0 to 4. So I think your outcome to me makes a lot of sense. And I think that more of our trials should accept that a modified Rankin score of 4 for patients who are this sick is a pretty good outcome, actually. Maybe we can talk a little bit, Dr. Beck, about some of the secondary outcomes that you were interested in.
Yes, of course, secondary outcomes were positive. So the shift analysis, which we didn't define as the primary outcome, was clearly significantly better. And the major finding was already discussed and touched by you, but it's worthwhile repeating it. We do not produce the most severely affected bedridden patients, but patients with a GCS of 4 or better. And in neither group, was an outcome of an MRS of 0 or 1. This simply did not happen. And this is what you also emphasize. We must really keep in mind what severely affected patients we're dealing with. And other secondary outcomes probably worth mentioning is that the reimplantation of the bone flap is already included in the outcome. So there are questions that are asked that what happens when we reinsert the bone flap, and do we hurt our patients? And this is already included in the primary outcome. So if we improve the system of reinsertion of the bone flap, we probably get an even better outcome for the switch population. Sorry.
Oh, no, sorry. That's a really interesting point that I think probably many people, maybe non-surgeons, don't consider as much as the importance of that part of the process.
Yeah. Then, of course, length of stay on the ICU was 4 days significantly, and 4 days shortened by the surgical procedure. This might be important, also cost-wise. And another issue we must mention is that the rate of shunt dependency was higher in the surgical group. So a little bit more, I believe it was 18% versus 8% that did need a shunt after surgery.
Great. Well, so that's, as we move into the results that you're discussing, unfortunately, the trial was not able to be led to completion. And so Dr. Fischer, can you tell us a little bit about why that was, and maybe if you can pontificate a little bit how you think it affected the outcome?
Yeah, excellent question. So first of all, SWITCH is an academic trial. So the main funder was the Swiss National Science Foundation, and we also received money from the Swiss Heart Foundation. Nevertheless, the budget for such a trial was limited. And the main issue was that the time frame from the grant was limited to 5 years. And we all know that if you do academic trials, you need to run these trials more than 5 years. And we tried to mitigate that by including more sites. So we had, as you know, more than 40 sites in the SWITCH trial. And we tried to encourage these sites to randomize as many people as possible. Nevertheless, after 10 years and cross-funding with other grants and whatever, we were just simply running out of money and we couldn't go any further. And also, there was also a change in evidence. You know, ENRICH was presented, and at a certain time point, you also need to show and to prove what the results are. I think for me, the question is whether it would have changed if we would have continued. Eventually, we would have a p-value which would have been below 0.05. Nevertheless, I do not emphasize too much a p-value in superiority trials, because whether the p-value is 0.056 or 0.049, I don't care. For me as a clinician, I have to balance the risks and benefits, and I do want to know what are the chances for my patient in having a modified ranking scale of 0 to 4 versus 5 to 6. And at the end of the day, we have to translate these findings anyway into our clinical practice. And therefore, I think it doesn't really change my attitude towards the findings. And I'm much more interested in the treatment effect. And if you look, you have a relative risk reduction of 13%. So look at all the other ICH trials, Interact, the TITCH trials and the STITCH trials. In which trial have you ever seen such a huge treatment benefit? And whether that's significant or not, the treatment effect is there, and you do not have any other treatment for these people.
Yeah. I completely agree. And I would argue that those trials don't really represent this population, do they? I mean, no one has shown benefit in a patient population with such severe ICH. So I really commend you for completing this. And I can't imagine how many late nights and just endless grant applications that must have been involved in this huge endeavor. You mentioned the main result, which is this 13% reduction. Were there any subgroups of patients that seemed particularly likely to benefit from decompression? Dr. Beck?
We're currently analyzing the data set, but there doesn't seem to be a strong signal from any of the subgroups. The major finding is that this is already a very highly selected subgroup, and there is no benefit for any other treatment, and probably we found one for this highly selected group. And as far as I can tell you now, there doesn't seem to be a signal from age, gender, even timing, interestingly, and doesn't have to have an additional effect. But we are currently analyzing the subgroups and will, of course, report our findings to the community.
Yeah, that's very interesting. I think a lot of us put a lot of emphasis on age for decompressive craniectomy in the ischemic stroke group, based on Destiny 2 and prior trials. And so interesting that you did not find a similar effect or interaction with age.
Yep.
Great. Now I sometimes pour through the supplemental data because I just sort of a nerd like that, and it helped when I looked at the trial. What I really noticed was there seemed to be a very sudden kind of divergence in the mortality curves, and this happened in the first few days. And in some ways, it seems like maybe this really drove the result, that we were saving lives and perhaps putting more of them into a 4 than a 5. But it happened seemingly very early. Do we know how these patients died?
Well, that's an excellent question, and we had a lot of debate, whether we should somehow try to capture, whether the people have a withdrawal of care or not. It is very difficult to measure this and to investigate this in a multi-center randomized controlled trial. And we strongly believe that overall, people who are included in trials, they have a better outcome than people who are not in a trial. So first of all, and I think that is also one of the major findings from previous ICH trials, for instance, also the MISTY trial, that even in the best medical treatment group, the outcome is much better compared to daily clinical practice, because people take care of these patients, they try to ventilate them, they try not to give up. Whether the withdrawal of care has made an impact is possible, but we cannot prove it, and it was impossible to measure that properly in a decent way.
Great. Now you mentioned some of the issues with the craniectomy and placing the bone back on. There were some interesting secondary outcomes that I found, and some of these were surprising to me. So one of them was you looked at all sorts of quality of life measures, and you looked at pain and discomfort. And it was one of the really few significant findings that patients that received decompressive craniectomy had less pain and discomfort, if I read that right, than patients that did not. What are your thoughts about that finding? Is that just a spurious finding, or do you think there's something real there based on your clinical experience, Dr. Beck?
This is a good finding, and of course we are happy about that, but we need to be honest, there are many secondary outcomes over the time, and this really, the benefit in having less pain and less discomfort in 180 days was not so strikingly there at after 1 year. And we have many other secondary outcomes that have not been specially picked up and were not significant. So we are lucky that we are happy that we have this finding, but I do not, to be very honest, I do not have an obvious explanation for that, and I don't know whether this is just an outlier. Of course, it's good, it's on the good side, but there is no systematic trend for that, to be honest.
Yeah, fair enough. Well, I think one outcome that maybe was not unexpected was that the patients that received decompressive craniectomy were more likely to require a CSF shunt. And can you explain a little bit why maybe that was something you were interested in looking at, and maybe what explains the result?
Probably we do disturb CSF circulation. We do disturb CSF circulation with any neurosurgical intervention, especially with a large craniectomy, and we open all of the subarachnoid space. So to be honest, this was not so unexpected by me or probably by the surgical group, that there is a disturbance in CSF circulation. And then you even need to find the very best time point of reinserting the bone flap to prevent or not to let a sinking skin flap syndrome happen. And so there is clearly a disturbance of CSF circulation once we open the skull, and especially if you open the skull as wide as we do. So probably this is a kind of an explanation. This comes not so unexpected to me as a surgeon.
Yeah, I agree. Any other differences in serious adverse events between the groups?
Yeah, I'm a neurologist, and a lot of my neurological colleagues say, well, this is big surgery, you're producing serious adverse events. And if you look at the tables in the paper, there was no significant difference in serious adverse events in between the two groups. And I think that's also a very important finding, which comes out of the switch trial. There are obviously serious adverse events, but they are high in both treatment arms. And there is no difference in between the DC plus BMT versus BMT group. And I think that's an important finding.
I agree. And I think sometimes we underestimate how many serious adverse events occur in just standard of care medicine, right? Especially in patients that are this sick. I wanted to go back to this question of outcome again, and I thought you all did a very clever thing, which is you asked the survivors from the surgery group if they would have undergone surgery again. And what did they say?
More than 2/3, 77% of patients said they would undergo the procedure again. This is an important answer, but on the other hand, on the other side, we didn't ask, or we couldn't ask the patients that died. And probably this emphasizes an issue we must talk about. This is an individual decision. And Urs Fischer pointed it out already. We don't really care whether the P was 0.055 or 0.0445. Even if it would be more significant, we cannot force this decision to anyone. So this probably should never be a standard decision, but we now can consider, and we know what are the risks and benefits of decompressing the brain in such severe circumstances. No more, no less. And there will ever be differences in different cultures and different countries. So all regional caregivers do have to ask themselves these questions, and it will ever be an individualized and highly individualized decision.
Wonderful. Have the results of the trial changed your practice at all, Dr. Fischer? Is this something that you were regularly offering to patients prior to publication?
I think I would like to follow what Jürgen Beck just has said. I think it remains an individual decision, but now I know what I can tell to the patients and the family. I can tell them what is the likelihood of having a modified ranking scale of 0 to 4 versus 5 to 6. I have some ideas about the mortality, and I also know a little bit the perspective on a 1-year follow-up. And I think at the end of the day, these are critically ill people, and therefore you have to talk to them. And it very much depends on the culture, the religion, and so many other factors. And you can inform the physicians, the patients and the families, and that's our task as physician at the end of the day. It remains a personal, individual decision.
And Dr. Beck, maybe I can ask you to place your neurosurgical hat on for a second. I imagine, knowing all that you know, it's still awful tempting to try to evacuate some clot. And so what is the role of clot evacuation here, if any? And are there ways in the future that you can see that we may be able to combine decompressive crani with clot evacuation? And maybe what are you doing in your practice, and where do you see us headed in the future?
Excellent question, a key question. And of course, we need to continue finding better and more subtle ways to remove the clot. I don't think that DC is the solution for ICH. It is just currently the best option we have for this highly selected group of patients. But we must continue with trials. And Rich has clearly shown that with the current methods, we are still too gross. There was no benefit in removing the clot from the basal ganglia, and they didn't even include the thalamus. So we must do a better job. This can only be done if we continue to include patients into studies, if we find clear numbers and thresholds for end of treatment volume, and probably we have a good estimation from the MISTI trials of 15 cc. But I'm quite convinced that removing every single erythrocyte to a volume of 0 would probably harm the patients. We must improve in timing. Why including patients in the first 24 hours if stroke medicine aims to at the treatment in the first minutes, and probably assisting with combination of methods, DC plus evacuation, or maybe there's a rebirth of neuroprotective stuff. And so we must continue. This is only the beginning, but I completely agree what you have said in the beginning. There is a new time for ICH treatment, and there is no place for nihilism.
Wonderful. Maybe Dr. Fischer, sort of similar question to you. What are you excited about when you think to the future of ICH care? What emerging treatments are you interested in?
Yeah, so first of all, I think that the beauty is that the nihilistic area is over. I think we now can say, so if you have a lobar hemorrhage, I think we have quite good evidence that you should go for endoscopic, evacuation of the hematoma. With deep, we can consider decompressive surgery. But as already mentioned by Jürgen, this is not the end of the story. So the main question is, blood does not belong into the brain, and it is a toxic substance in the brain. So therefore, we should try to get it out of the brain as fast as possible, but as good as possible without, without any further damage. And the main problem is that if you have a bleeding in the basal ganglia, you have a lot of fibers, and if you're going there with your surgical instruments, there is a potential danger that you are disrupting the existing structures. So we eventually need better devices, smaller devices, thinner, finer devices in order to remove the clot. And I think if we can achieve that, then we will succeed. I'm a stroke neurologist, and I'm also very much involved in ischemic stroke research. And I saw the evolution over time. We started with the big clots with the IC and M1 occlusion. Now interventionists have the option, have better instruments to go to smaller vessels. And I think the same has to happen also with ICH. I mean, the endoscopes we have so far, they're probably still too big, too disruptive. Eventually, we have better instruments in the future. I have a lot of hope in that.
Dr. Beck, from the technical side of this, are there things that you're seeing coming down the pipeline that you're interested in using and see as things that give us optimism for the future of surgical ICH management?
No, the development is so rapid. We will succeed in the long run, and we will get better instruments, better vision into depth, smaller endoscopes, better hemostatic material, more subtle approaches, and even the combination of interventional methods with minimal invasive surgical methods and the optimal timing. So I'm quite optimistic, but it will take time and will be bothersome. But there is light at the end of the tunnel.
Wonderful. Well, let's leave it on this optimistic note. I want to thank you both for joining us on the podcast. It's really been a pleasure. I've learned a lot, and I think we've all learned a lot from the switch trial. And so thank you to both of you for putting so much time and effort into this trial. And I can't imagine what you're going to do next. Maybe we'll have you back on in 2034 to discuss the results. And thanks to our listeners for tuning in. This has been the Neurocritical Care Society podcast. It's available wherever you get your podcasts, and continuing education credits are available for select episodes. Please like and subscribe, and tune in next time.